the privilege to introduce Dr. Andrew Trout, who is an associate professor of radiology and pediatrics, who's going to provide an overview of imaging modalities for pancreatic diseases. Andrew?
All right, thank you. So I've been giving kind of a monumental talk to talk about all imaging of all pancreatic diseases in 20 minutes or less. And so we will try to get there. Obviously, I can't go into all of the details here. I will be around, obviously, for the Q&A session and afterwards, so I'm happy to take questions and whatnot at that time. But I do want to make sure I touch on the various different diseases. So yes, I'm a pediatric radiologist, but I am adult trained as well. And so I am going to talk about tumor imaging as well a little bit in the course of this talk. So we got a lot to talk about and we'll jump right in. So here's the outline for the talk. I'm going to start by talking about imaging generalities based on disease categories. So that is tumor versus pancreatitis, and give you some generalities that hopefully you can take away. Talk a little bit about the advantages and disadvantages of the various different modalities. Obviously, we can't get into every little indication of when you might use one modality over another, but I do want to sort of point you, give you some tools to help you potentially make those decisions. A couple of protocol considerations and tips to keep in mind for you to chat about with your radiologist as you're putting these exams together. And then just a little bit of education about what to look for when you are doing imaging for pancreatitis. And then if we have time to get to it, I have some stuff in here about future directions, where we're going with imaging. That is in these slides that are in your slide deck as well, in case we don't get there. And again, my email address, Twitter handle, all that stuff is on the front slide. Please do contact me. I'm happy to discuss any and all of this. So when we think about pancreatic disease, quote unquote, which is what this whole thing is about, there's really two main categories, right? There's pancreatitis, and then there's this whole category of pancreatic tumors. And the imaging modalities are the same, but the approach to going about how you would image these diseases does differ. So there are people coming along that have been talking about ERCP and EUS and that sort of thing, so I'm not going to focus on that. I'm really talking about the non-invasive techniques here. And when it comes to pancreatitis, really ultrasound, transabdominal ultrasound, CT, and MRI are your main imaging modalities. With regard to pancreatic tumors, ultrasound doesn't really play a role there. You may discover tumors by ultrasound, but in terms of actual imaging of the tumors, characterizing those tumors, ultrasound just doesn't get the job done. And so you're really looking at CT or MRI when you're talking about pancreatic tumors. So this is probably the most important slide in the entire deck. You'll see it at the end of the deck again as well. This is really just sort of laying out the advantages and disadvantages of the various different modalities to try and help you make those decisions about which modality to pick when you're choosing how to go about imaging your patient. So you're familiar with many of these things. I have a couple of asterisks here, particularly with regard to the radiation or no radiation. There was this all this hype and concern about radiation exposure, particularly the pediatric population that comes from CT. And so we have been choosing modalities that are radiation free simply to avoid radiation exposure, when in reality we're probably making some diagnostic compromises by choosing those modalities simply on the basis of the lack of radiation exposure. And I will tell you that in the current era, particularly at academic institutions, and even the vendors are starting to make advances, CT doses are going down, 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 down. And it is very acceptable to use CT, both in children and in adults. And so I don't want people to be running away from CT simply because that it utilizes radiation. Okay, so that's why there's asterisks there. So just in general terms, ultrasound is highly available and it's portable. It's very non-invasive. You don't need an IV. You don't have the radiation associated with it. So it's a very good starting modality for a lot of the diseases we talk about. But you've all seen this clinically, right? It can be limited in the bigger patients, and the world is getting bigger, or at least the people in the world are getting bigger. So ultrasound is more and more being limited, can also be limited by bowel gas. And it really doesn't quite get the job done when it comes to assessing the blood vessels for complications in surgical planning. CT, we talked about radiation already. When you think about CT versus MRI, one of the big advantages of CT is your spatial resolution, generally, and the fact that you can see calcification. So that's particularly important in adults when you're dealing with calcific chronic pancreatitis, looking for those calcified stones. Less important in pediatrics, but you will miss calcifications by MRI. In fact, they can often be invisible. CT also has a big advantage of speed. So if you need cross-sectional imaging in that critically ill patient, that patient doesn't belong in the MR scanner. Get that CT scan done and get them back up to the ICU, particularly if they're sick. MRI gives you your best soft tissue contrast, okay? So MRI really lets you look at the soft tissues, characterize the parenchyma of the gland, look at the duct, look for those abnormalities that we see in association both with cancer and with pancreatitis. You can often do MRI without contrast as well. And so you can avoid an IV in those patients or avoid contrast exposure, which is an entire conversation in and of itself. I do have endoscopic ultrasound and ERCP on here because, again, these are important. They're the modalities that allow you to intervene, right? I can't intervene yet with my ultrasound, my CT, or my MRI. Our endoscopists certainly can, and they are right up against the pancreas, so there's something to be said for that as well. So all these modalities have their places. Again, this is an important slide. It's really just there to give you some tools to make decisions. Back to the categories of disease, start with pancreatic tumors. As I mentioned, CT and MRI are going to be your main modalities for imaging of pancreatic tumor. And what are we looking for, or what should you be looking for when you're imaging tumor? And really, obviously, we're looking for the presence or absence of tumor. But one of the critical questions is the status of the vessels, the relationship of the tumor to the blood vessels, because that has implication for surgical and medical management. And so that's where you need the imaging that you can get with CT or MRI as opposed to with ultrasound. Invasion of local structures also is critically important, and then the presence of metastatic disease. CT and MRI give you that huge field of view that you can't get with ultrasound without significant effort, and so you really do need those modalities when you're looking for metastatic disease. So here are a couple of imaging examples in a patient with a large pancreatic tumor. You can see on ultrasound delineated here by these yellow arrows, a very heterogeneous mass, but you see very quickly how you're not really seeing the margins of the mass, you're not seeing the relationship of the mass to the other structures, whereas you get a CT on the same patient, again, we see that same tumor looks very similar, but we see its relationship to the supramesenteric artery and the supramesenteric vein, to the renal hilum where it's approaching and possibly invading, and on some other images extending up into the porta hepatis. So you really do get a lot more information with CT and MRI, and again, ultrasound doesn't really play a significant role in the imaging of tumors. One critical point is when you're imaging tumors, again, because one of the critical decision-making points here is invasion of other structures and the relationship to the blood vessels, IV contrast is pretty much mandatory. With MRI, we're getting to a point where we can do some imaging without intravenous contrast, but it's still a little bit early to do that. And so as a general rule, you're gonna need intravenous contrast in your assessment of pancreatic tumors. Now, in terms of intravenous contrast, it's important to get multi-phase post-contrast imaging. So after you give it a bolus of intravenous contrast, you can acquire various different series of images. You can acquire a single time point. Most CT exams, when you order them out of the emergency department, are acquired in what we call a portal venous phase, right? So it's a 60 to 70 second delay. It's designed to optimize enhancement of the solid organs and to give you both arterial and venous enhancement. But when you're talking about a tumor and you're particularly concerned about the arteries, you want to acquire actually an earlier phase of imaging to get a really good assessment of those arteries, get really robust enhancement of those arteries, as well as get that portal venous phase imaging. So when you're imaging tumors, you're going to acquire multi-phase imaging. Sometimes you're going to do an on-contrast sequence, but you're generally going to do an arterial and then a portal venous phase sequence. Oral contrast can be helpful. It's not mandatory, but it can help to separate those bowel loops from tumor mass and understand the relationship of the bowel loops to tumor mass. And MRI versus CT in the context of tumors really comes down to your individual practice preference and to some degree your strengths, right? Big academic institutions are going to often lead toward MRI because they can do it well. They have the resources to do it well. Private practice, it's much easier to accomplish a CT reliably and get good quality imaging. So either is fine, and it's really a preference. So here's another example of a pancreatic tumor. I've outlined the tumor with the yellow dotted line there and showed you the blood vessels there with red and blue arrows, arterial and venous respectively. So you can see on the CT here the relationship of this tumor encasing and narrowing the portal vein here on the coronal reformatted images, partially surrounding but not technically encasing the arteries and having no definable soft tissue plane with the superior mesenteric vein there. So this is the data, the information that the CT gives you. We also see the tumor extending up into the porta hepatis. So cross-sectional imaging in the context of tumor is critical. There are other modalities that do play a role here, certainly EUS and ERCP to understand, to get biopsy, obviously to understand relationship to ducts, et cetera, and FDG PET plays a role when you're assessing for metastatic disease, but I'm not going to get into those in the context of this. So moving on to pancreatitis. With regard to imaging of pancreatitis, IV contrast is really a must when it comes to CT to really get that soft tissue enhancement, the liver, the pancreas enhancement, understand the relationship of the vessels. There are data out there that have shown that a single phase that portal venous phase is sufficient. You don't need that arterial and portal venous phase imaging when you're imaging pancreatitis for the vast majority of cases. If you have a specific question with regard to the arteries, it can be helpful to get an arterial phase, but in general terms, doing both an arterial and a portal venous phase exam is not necessary in pancreatitis, okay? And the reason we try to get away from that is you really are CTing that patient twice. So if you are concerned about radiation exposure, that patient is getting double the dose. IV contrast is not necessarily mandatory for MRI when you're looking at pancreatitis. It can be helpful when you're looking at autoimmune pancreatitis to see some of the secondary findings. It can be helpful when you're assessing for necrosis, though non-contrast MRI is very robust for the assessment of necrosis. But it is, again, helpful for looking at the vessels. So you have to have it for CT. You don't necessarily need it for MRI. With regard to oral contrast, we basically never use oral contrast for MRI for pancreatitis. It's a plus or minus when it comes to CT. Sometimes it can be helpful to separate fluid collections from bowel loops. So it can be helpful in that context. And then one other sort of recommendation with regard to imaging of pancreatitis, when you MRCP, magnetic resonance cholangiopancreatography, it's just an MRI designed to look at the pancreatic ducts. But those are the protocols you're gonna be doing here. Build redundancy into those. Those are difficult exams to do well and to do right. And so if your radiologists are on this, they're going to be building in additional sequences to give you multiple opportunities to look at that pancreatic duct to make sure that on your one go, you don't miss it. And so our protocols actually tend to be a little bit longer because we're requiring multiple different sequences to get a look at the duct. Guidelines exist out there for imaging of pancreatitis in the adult population. This is the chronic pancreatitis guideline. I've given you the reference there. There are details there that I'm not going to go into, but they're there and available for you. And now I'm going to move on to a little bit of just training your eye to see a few things that we as radiologists are looking for when we're imaging pancreatitis. And really this breaks down to two categories, though there is often superimposition of acute pancreatitis on chronic pancreatitis. But when we talk about acute pancreatitis, we're talking about swelling, edema, fluid collections, and necrosis are the things we're looking for. And in chronic pancreatitis, we're really talking about disease of the parenchyma and disease of the duct and the various different findings we can see in those two areas. So here are imaging examples of chronic pancreatitis, ultrasound, CT, and MRI. In all of these cases, you can see swelling of the gland, so the gland is enlarged. On MRI, you can actually identify the edema based on the T2 signal chain, so the pancreas is now appearing somewhat brighter on these T2 weighted images, okay? We see fluid collections on MRI here, acute peripancreatic fluid collections or acute necrotic collections in this particular case here. And in this case, we did give intravenous contrast, and there's absent enhancement of essentially the entire pancreas. So there's near pan-pancreatic necrosis here. So because the pancreas is necrosis, this collection actually turns out to be an acute necrotic collection rather than an acute peripancreatic collection. And that gets to this slide. So there are specific definitions, and your radiologist should be using these specific terms to describe the fluid collections that occur in the context of pancreatitis. And the reason for these definitions is they have management implications, as we'll hear when we get to the endoscopic duct, right? And really what you are trying to separate is the necrosis versus just that bland, simple fluid, okay? Because necrosis generally requires some form of debridement to deal with, as opposed to the bland fluid collections, which will either resolve or can be drained minimally invasively, okay? And so the main fluid collection types, you are separated first by acuity, and then based on the content of those collections. So in the acute context, you have acute peripancreatic fluid collections, or APFCs, and acute necrotic collections. And that's simply based on the presence or absence of necrosis, okay? So APFCs, those acute peripancreatic fluid collections, have no necrotic debris in them, and they're associated with non-necrotizing pancreatitis. So this is edematous pancreatitis, right? So it's that weeping or accumulation of fluid. Whereas the ANCs, or the acute necrotic collections, are associated with necrotizing pancreatitis, and they contain fluid and necrotic debris. And they can be both intra or extrapancreatic. In the chronic phase, when these collections start to organize and develop that investing wall, which is when they can be intervened on, the APFCs, those simple fluid collections, are the ones that turn into the pseudocysts. And the ANCs, the necrotic collections, are the ones that turned into the walled off necrosis, okay? And again, what we're looking for in the chronic phase, there is a time interval of generally 4 weeks, but we're looking for an investing wall around the collection that gives it that stability that allows our endoscopic colleagues to go in and intervene, okay? It gives it that stability so they can get in there endoscopically. Here are some examples of imaging findings in chronic pancreatitis. So when it comes to the parenchyma, we're looking for atrophy or loss of bulk. On MRI, we're looking for loss of T1 signal. So normally on a T1 weighted image, the pancreas is the brightest organ in the abdomen. In this case, the pancreas has completely lost its signal and it's essentially black, okay? Calcifications, as I mentioned, you'll see by CT, but you're not gonna see them by MRI. Here are duct changes of chronic pancreatitis with dilation of the main duct and side branch, irregularities and narrowing, okay? And here's a CT example demonstrating a few calcifications. So that's kind of a whirlwind tour of imaging as it currently stands. I did want to touch a little bit about where we're going forward at this point. Some of these techniques are going to be applicable to research projects you may be developing going forward. One of the big things that's exciting is faster MRI protocols. That's one of the main limitations of MRI. The exams are long. Kids will often need sedation. Well, more and more, we're starting to do these fast 5-minute protocols that may allow you to do an MRI in the ER, right? People are doing it for appendicitis. Even in very young kids. And if you know the literature in acute pancreatitis, ultrasound is only somewhere between 20 and 60% sensitive, right? Well, if you can throw a patient in the MR scan and require 1 or 2 sequences and have near 100% sensitivity, that's gonna be a significant diagnostic advantage, right? And then we're trying to get more quantitative. I showed you some findings, loss of signal, atrophy, that's all very qualitative, right? And we're trying to move into the quantitative space to make these more reproducible. So here's an example of the sequences you might acquire in a rapid MRI protocol for pancreatitis, just 2 axial sequences with and without fat fluctuation, perhaps 1 coronal sequence. This could be easily done in less than 15 minutes, but easily be done free breathing and without intravenous contrast. So it's very accomplishable in the ER. Lots of quantitative measures coming forward, and I'm running low on time, so we won't get through all of these things. But we're looking at how we go about measuring the pancreas instead of me just saying, yeah, there's atrophy. We're looking at pancreatic stiffness as a non-invasive measure of fibrosis. We're talking about MR signal mapping. A lot of this is being discussed across the street right now, actually. And then I believe you already heard a little bit about use of secretin for exocrine function. So with regard to the question of atrophy, there are normative measures for pancreatic thickness, a linear thickness, but the pancreas is a very sort of irregular organ, and these measures are nowhere near reproducible. So more and more, we're starting to get into doing volumetric measurements, either manual segmentation or automated segmentation of the pancreas. So you get simply a mass of pancreatic tissue, and it's no longer based on how someone's pancreas happens to lay in the abdomen. This may be a more sensitive measure of parenchymal volume change. Elastography is a non-invasive way to measure tissue stiffness. So it's analogous to palpation, right? Cancers feel hard, fibrotic tissues feel hard. Well, we can now measure that hardness or that stiffness with elastography, and that can be accomplished both with MRI and with ultrasound. There's a pulse that goes into the body, and the waves that are created by that pulse in the tissue are tracked by the imaging modality, and you can actually non-invasively measure stiffness. So we can do this with MR, we can do this with ultrasound, and so there's promise there in terms of non-invasively detecting the fibrotic changes that develop in the context of chronic pancreatitis. There are data out there that have shown that we can separate degrees of severity of pancreatitis on the basis of stiffness measures by elastography. So those data do exist. We're also looking at signal mapping. So remember I said that the pancreas should be the brightest organ in the body on T1 weighted imaging. So here's a normal pancreas, right? T1 weighted imaging, that pancreas is the brightest organ in the body. Here's a patient with chronic pancreatitis. The pancreas has lost not only its bulk, but its signal. So instead of me qualitatively making this statement, I can actually measure that signal now on carefully acquired MR sequences and get actual quantitative measures of T1 weighted signal, which have been shown to correlate with grades of pancreatitis, at least in adult populations. So something quantitative coming there. And then you heard about this briefly before, but using secretin not only to improve visualization of the duct, but also to look at what sort of exocrine response you're getting by quantifying the fluid volume that's produced and ejected into the small bowel, okay? So we can do that quantitatively. So again, this is the most important table in the entire talk, okay? So if you take, in terms of your day-to-day use in clinical practice, this is the table I want you to leave here with. And again, it's in the files that you have in terms of helping to select one modality over another. And that's how you get a hold of me, okay? So a lot to cover, whirlwind tour, fast, sorry, but again, I'm around and please don't hesitate to reach out.